Hi, everyone. My name is Mark Steven. I'm the president of IUSTI Canada, and I'm very pleased to welcome you to this IUSTI webinar series. Today's topic is sexually transmitted infections and preterm birth. And we have for objectives to talk about preterm birth, the causes, diagnosis, and therapeutic interventions, the current evidence linking STIs to preterm birth, the vaginal microbiota as modulator of preterm birth risk, and knowledge gaps in STI-PTB research, the causality mechanism, and relationship with other pregnancy complication. It's my pleasure to introduce Dr. Karen Lithgow. She's a postdoctoral research associate at University of Calgary. She is a CIHR Banting-funded postdoctoral fellow working with Dr. Laura Sycuro at the University of Calgary. Dr. Lithgow also investigated the vaginal microbiome with a focus on how microbiome enzymes contribute to vaginal health, sexually transmitted infection, and pregnancy complication. So it's my pleasure to leave the microphone to Dr. Lithgow. Please, Dr. Lithgow.
All right, thank you so much. Thank you very much for the opportunity to speak today. I'm really excited to be invited and get to speak on one of my favorite topics. So like Dr. Stebbin said, I studied syphilis pathogenesis with Dr. Caroline Cameron during my PhD, and currently I'm working with Dr. Laura Sycuro at the University of Calgary, studying the vaginal microbiome and risk for STIs and pregnancy complications. So today's topic, I'm going to be talking about sexually transmitted infections and their risk for preterm birth. And I do just want to acknowledge that I'm coming from you here in the city of Calgary, and I work and play on the traditional territories of the people of the Treaty 7 region in southern Alberta, including the Blackfoot Confederacy, which includes the Siksika, Kainai, and Piikani nations, the Tsuut'ina First Nation, as well as the Stoney Nakoda nations, including Chiniki, Bearspaw, and Wesley nations. And the city of Calgary is also home to the Métis Nation of Alberta, Region 3. I also want to acknowledge that the work today discusses sex and gender in the context of sexual and reproductive health. Because we are discussing pregnancy and in particular preterm birth, this presentation will focus upon individuals who have a vagina, cervix, and uterus, but this is inclusive of any gender expression. And please feel free to get in touch with me if you notice anything I can improve upon with respect to discussing these topics in an inclusive and respectful manner. So today I'll be talking about some of the basics of preterm birth. What is it? What are the causes? What do we know about how sexually transmitted infections contribute to preterm birth? How does the vaginal microbiome modulate preterm birth risk? And what are some of the key conclusions, gaps in knowledge, and areas for additional research? So broadly speaking, preterm birth is birth before 37 weeks gestation. So a term birth is typically defined at an average of 40 weeks gestation, and birth before 37 weeks is preterm birth. And during this late second and third trimester, we see important development happening in the neonate, and this includes development in the central nervous system, ocular region, lungs, as well as teeth. And as a result, babies that are born prior to term often will have complications. This can include perinatal mortality, as well as short and long-term morbidities. And these tend to be morbidities associated with insufficient development in regions like the central nervous system or respiratory system. Preterm birth can be subdivided into different categories based on the gestational age at birth. So extremely preterm birth is defined as birth prior to 28 weeks gestation, and we tend to see the poorest prognosis among infants born within this window. Very preterm birth is defined as 28 to 32 weeks gestation, and moderate to late preterm birth is 32 to 37 weeks gestation. Now, data from 2020, there was about 5.3 million deaths among children younger than 5 years old. And these deaths are primarily due to complications from preterm birth. So about 17.7% of death in children under 5 can be attributed to complications from preterm birth. Preterm birth affects about 10% of pregnancies. In 2020, there were 13.4 million babies born preterm, and it is a leading cause of both neonatal morbidity and mortality. Now, there are significant short and long-term complications that arise from preterm birth, and this is for both the child and for the families. So in terms of the neonate, the neonate is at risk for infections, sepsis, and meningitis, as well as acute pulmonary complications. Throughout childhood, preterm children will be at risk for respiratory complications, as well as cardiovascular and neurological complications. And there are also long-term complications that arise in the birthing parent with respect to their cardiovascular system. In addition to these morbidities, we also see significant psychosocial stress for families, as well as financial challenges as a result of dealing with these significant disabilities. And we see that there's an increased risk for neonatal deaths and neurodevelopmental disabilities when preterm births occur in that extremely preterm birth gestational window. So when birth is prior to 28 weeks gestation. So although the highest burden of preterm birth occur in that moderate to late window, we do see that when infants are born preterm, about 82% will experience neonatal death, and about half of the survivors will experience neurodevelopmental disability. And those burdens decrease in proportion with increasing gestational age. Now, these are averages across the globe, but we do see major differences in low versus high income settings. So in a low income setting, about 90% of extremely preterm babies will experience neonatal death compared to about 10% in high income settings. And this can really be attributed to inadequate resources to properly care for those preterm neonates. So the global burden of preterm birth usually averages out around 10%, but can be quite different in different geographical regions. So it can range from 4 to 16%. And in Canada, the latest data shows about 8% of babies are born preterm. And in terms of morbidity and mortality, we see that in high income settings, there is a lower burden of death and severe or mild impairment, whereas in lower income setting, there's an increased burden of these adverse outcomes. Now, the rates of preterm birth have not changed much in the last decade. So we see in 2010, 2015, and 2020, the rate of preterm birth is about 10% worldwide. And the highest rates of preterm birth tend to be observed in Southern Asia and Sub-Saharan Africa. And so this really speaks to the fact that we haven't had much success in reducing the burden of preterm birth or coming up with therapeutic interventions that significantly reduce that burden. So preterm birth, I've kind of talked about it so far as this monolith, but it really can be subdivided into these clinical subtypes. So medically indicated accounts for about 3.3% of births. And this is where the pregnant individual may have an indicator of risk for preterm birth with a pre-existing condition. So this could include gestational hypertensive disorders like preeclampsia, or placental abruption, intrauterine growth restriction, or fetal demise or distress. But the other subcategory of preterm birth is called spontaneous preterm birth. And this can be divided into preterm premature rupture of the membranes. And this is where the chorioamniotic membranes that encase the neonate and amniotic fluid prematurely rupture. And this poses a significant risk for infection. And often these patients will be induced to labor if they're not already in labor. Idiopathic preterm birth is where there's an unidentifiable cause of preterm birth, and there's uterine contractions and progressive cervical change that ultimately results in preterm birth. Threatened preterm labor is where uterine contractions and cervical changes are occurring, and about 50% of those patients go on to deliver, but threatened preterm labor can sometimes resolve in about 50% of those patients. So the causes of spontaneous preterm birth are diverse. There's multiple causes. This can include cervical disease, uterine overdistension, stress, as well as vascular disorders. But it's thought that infection is the cause of spontaneous preterm labor in about 40 to 60% of cases. And there are two routes of intrauterine infection. So there can be an ascending infection where bacteria or viruses colonizing the vagina vertically migrate into the uterus, causing infection of uterine tissues like the chorioamniotic membranes. Or there can be a disseminated infection where pathogens move through the bloodstream and either colonize the placenta or traverse across the placental blood barrier to infect the neonate and amniotic fluid. Now, in terms of mechanisms, it's been proposed that the presence of bacteria in the uterus and the presence of their inflammatory cell wall components triggers different pathways that lead to preterm labor cascades that include uterine contractions, rupture of that chorioamniotic membrane, as well as cervical ripening and dilation, and that is what ultimately results in preterm delivery. So just to summarize some of this key information from this first section, we know there are different subtypes of preterm birth. There are multiple causes of preterm birth, and there are several clinical and behavioral risk factors. So some of the clinical risk factors can include preeclampsia, and behavioral risk factors can include things like smoking or a prior preterm birth. And earlier gestational age tends to be linked to poorer outcomes, and this can be subdivided into 3 different windows. So now I'm going to get into sexually transmitted infections. So in most parts of the world, we see that STI incidence has increased within the last decade. And in Canada, we see that all 3 bacterial STIs increased within the same period. So chlamydia rates have increased by about 33%, gonorrhea rates have increased by about 181%, and infectious syphilis rates have increased by about 400%. We see that chlamydia has the highest burden and syphilis has the lowest burden in terms of total number of cases. Now, thinking about this in the context of pregnancy, there's a real lack of pregnancy-specific data on STIs, but we do know that chlamydia infections are higher in females and tend to be higher among individuals under the age of 25. We do have better data on infectious syphilis and congenital syphilis during pregnancy. And we do see that there are significant increases in congenital syphilis over the last few years in Canada. There's better data on STI rates in pregnancy from the US. So from the period of 2016 to 2018, there was increases in all 3 bacterial STIs. So a 2% increase in chlamydia during pregnancy, a 16% increase in gonorrhea, and a 34% increase in syphilis. So what do we know about these sexually transmitted infections and adverse pregnancy outcomes? So syphilis, which is caused by the spirochete bacterium Treponema pallidum, is well established to cause congenital infections. So it can cross into infect the neonate and impair fetal growth, contribute to neonatal or perinatal mortality. It can also cause chorioamnionitis, so this is rare. Chlamydia is caused by the pathogen Chlamydia trachomatis and is well established with a link to pelvic inflammatory disease and infertility and ectopic pregnancy. There can be vertical transmission to infect the neonate during vaginal birth, and this often results in pneumonia. And similar outcomes are observed for gonorrhea, which is caused by the bacterial pathogen Neisseria gonorrhea. And so what is less well understood is how these different bacterial STIs contribute to preterm birth and preterm premature rupture of the membrane. So I'm going to go through a couple of recent studies that have looked at the relationship between these STIs and preterm birth to really highlight some good aspects of these studies and then some limitations of studying complex STIs with a complex pregnancy complication. And then I'm going to dig into specific data for each of the STIs to really drill down into whether there's a significant association between the STI and preterm birth. So in 2021, this was published in JAMA. This is the largest population-based study to date, located in the US. And this included 14 million births between the years of 2016 to 2019, and this is based on public health records. So what they found in this study was that any STI seems to increase the risk for preterm birth. So in their first model, they adjusted for age, race, and ethnicity, which are known risk factors for preterm birth. And in the second model, they included those same adjustments, but also adjusted for parity. So it's known that multiple pregnancies increase the risk for preterm birth. A history of preterm birth increases the risk. So they really factored in a number of different confounders. And they did find that after adjusting for this socio-demographic and medical and health factors, this reduced the association between STIs and preterm birth. They also looked at different gestational windows. So extremely preterm birth, very preterm birth, and moderately, those three different gestational windows. And with this data, they found that effect sizes were larger in this very preterm birth window, specifically for gonorrhea, syphilis, and any STI. There were several limitations to this study. So because it's this large population-based study, which allows you access to a huge number of data points, but there's a limitation in that not all data is available for the analysis. So antibiotic treatment is assumed in this case because patients were diagnosed with these STIs, but there's no documentation on the timing of treatment or what antibiotics were used. They also don't subset by different preterm birth types. So they don't separate by spontaneous, medically indicated, or PPROM. And there's no information on the timing of infection or diagnosis. So whether the infection occurred and was diagnosed and treated early in pregnancy versus close to the time of birth. So this second research study also published in 2021. This was a nested longitudinal study based in Western Kenya. In this study, they had a median age of diagnosis at 26 weeks gestation, so later on during the pregnancy, and all patients were documented to have received treatment, although a test of cure was not conducted. They found that diagnosis with any STI, so this could include trichomoniasis, chlamydia, gonorrhea, syphilis, or HIV, significantly increased the risk of preterm birth, and this was despite these patients receiving treatment. Chlamydia, gonorrhea, and incident HIV during pregnancy was also significantly associated with preterm birth when these were looked at individually. While bacterial vaginosis, which is a dysbiosis of the vaginal microbiome, was not found to be independently associated with preterm birth, the authors did find that abnormal vaginal discharge and cervical inflammation were associated with preterm birth. In a multivariate model, they found that any STI, chlamydia infection, or incident HIV were all significantly associated with preterm birth. So again, several limitations to this study. Their gestational age was determined by patient report of last menstrual period, which is not as accurate as prenatal ultrasound, which can affect the associations with the gestational age and really defining that pre or post 37 weeks birth. They did not account for prior preterm birth or other pregnancy complications that have been linked to preterm birth risk in their analysis. They did not subset by preterm birth type and did not test for STI cure. So although these patients received treatment, we have no information about whether they were cured throughout their pregnancy. So going through these two studies, I really just want to highlight some of the complexities of designing and analyzing and interpreting these studies. So in terms of our exposure, looking at these different sexually transmitted infections, there's complications that arise from knowing the timing of infection, what diagnostic test was used for the STI, whether antibiotic treatment was documented, the timing of that treatment, and whether a test of cure was done. In terms of our outcome for preterm birth, some studies, but not all, subset by clinical subtype, gestational age at birth. Some adjust for known confounders like prior preterm birth, demographic and behavioral factors, as well as other pregnancy complications. But these are all factors we need to think about when we're looking at this literature. So now I'm going to dig down into the current data for each of these STIs and kind of summarize everything that's known. So as I've mentioned, we are seeing increased rates of congenital syphilis, indicating that there's increased rates of syphilis in pregnant individuals. So screening for syphilis during pregnancy, the Canadian Public Health Agency of Canada does recommend all pregnant individuals are screened during their first trimester, and then screening is repeated later in pregnancy and at delivery, specifically for individuals at high risk of acquiring syphilis. But more frequent screening may be recommended in patients with risk factors. In the US, CDC also recommends universal screening at first prenatal visit, and similarly, third trimester and at delivery for individuals with risk factors. All right, so getting into the data, a meta-analysis of 6 case control studies found that untreated syphilis during pregnancy increases the risk for adverse pregnancy outcomes. So this is lumping together stillbirths, congenital infections, preterm birth, and low birth weight. Subsetting these by different adverse pregnancy outcomes, the authors also found that prematurity or low birth weight was significantly increased risk when pregnant individuals were infected with syphilis. Now looking at population-based cohort, this study subsetted both by preterm birth subtypes as well as the different gestational age windows, and found that syphilis infection during pregnancy significantly increased the risk for all preterm birth subtypes, as well as extremely preterm birth, very preterm birth, and moderate or late preterm birth. So you can see in this summary of the results in the graph on the right, there's a significant increased risk for preterm birth prior to 32 weeks with any of those clinical subtypes, as well as between 32 and 36 week window for either subtype. And then for earlier than 32 weeks, significant association with preterm premature rupture of the membranes and medically indicated preterm labor, but not spontaneous preterm labor. So in terms of syphilis treatment during pregnancy, we know that adequate treatment reduces the risk for preterm birth. So this is from a meta-analysis, and we see that when we compare treatment versus no treatment, there's a 61% reduction in preterm delivery, and this is based on 8 studies. When we compare adequate treatment, where patients receive at least 2.4 milliunits of penicillin 28 days before delivery, versus inadequate treatment, which would be a lower dose or closer to late gestational age, we see a 47% reduction in preterm delivery. And then when we compare adequate treatment versus treatment received during the first trimester versus late treatment, there's a 49% reduction in preterm delivery. And not only does antibiotic treatment reduce preterm delivery, but as you might have guessed, it also reduces congenital syphilis, stillbirth, and neonatal deaths. There is an increased risk for the Jurich-Herxheimer reaction, which results when a spirochete infection is treated with antibiotics, and the release of cell wall can trigger an inflammatory reaction. So some of the reactions that occur here kind of mimic preterm labor. So you can have contractions in the uterus, uterine irritability, and fever. And this occurs on average within 10 hours post-treatment and resolves within 24 hours. So summarizing this data, we see there is high quality data confirming an association between preterm birth and syphilis. And part of the reason we can be confident in these associations is because we have the most reliable pregnancy-specific estimates for syphilis due to the screening efforts to try and reduce congenital infections. We see from meta-analysis that antibiotic treatment does reduce preterm birth, as well as other adverse pregnancy outcomes. So next, moving on to gonorrhea, we see that these infections tend to be higher in males, but there are increasing rates of gonorrhea in pregnant individuals in the US. Canada recently updated recommendations for screening of both chlamydia and gonorrhea in pregnancy. So just updated earlier this year, they're now recommending that asymptomatic pregnant individuals are screened at the first trimester or first antenatal visit, and then screened again at the third trimester if no prior screening has occurred. In the US, the CDC recommends screening at the first prenatal visit for individuals that are under 25 years of age or are at increased risk of infection. And again, recommend additional screening for individuals with continued risk factors. All right, so digging into the meta-analysis of gonorrhea and risk for preterm birth, we see that both with unadjusted and adjusted analyses, there's a significant increased risk for preterm birth with gonorrhea infection during pregnancy. And this association holds both in high income and in low income settings. So this meta-analysis does show gonorrhea is associated with an increased risk for preterm birth. Now, in terms of antibiotic treatment, there's a real lack of data looking at whether antibiotic treatment for gonorrhea reduces the risk of preterm birth. In this study, the authors treated gonorrhea infection with antibiotics. This treatment occurred at variable times throughout the pregnancy and found still a significantly increased risk for preterm birth despite treatment with antibiotics, though they did not perform a test of cure. In another study where patients were tested for gonorrhea at each trimester and treated same day, there was no association with preterm birth, but individuals who were asymptomatic and did not receive treatment had an increased risk for preterm birth, with about a 3.3-fold increase with that adjusted odds ratio. And so really there's insufficient evidence to say that the efficacy of antibiotic treatment could reduce the risk of preterm birth. And this is corroborated by a recent meta-analysis that looks at the relationship between sexually transmitted infection treatments and preterm birth risk. So they had sufficient evidence to look at the association with chlamydia, syphilis, and antibiotic treatment and the risk for preterm birth, but there were insufficient studies to look at that relationship with gonorrhea infection. So summarizing this data, most of the primary literature published within the last 20 years shows that gonorrhea infection does increase the risk for preterm birth. So 11 out of the 13 studies and 2 meta-analyses also support this association. But we are lacking in antibiotic intervention studies to understand whether we could reduce this risk by intervening with antibiotics. Now moving on to chlamydia infections, again, not a lot of data on numbers of chlamydia infections in pregnant women in Canada, but we do know that they're increasing in the US. As I said, Canada recently updated their guidelines for screening for chlamydia and gonorrhea during pregnancy. And in the US, chlamydia is recommended to be screened for in pregnancy for individuals under 25 or those that have risk factors. All right, so this meta-analysis study included 30 different publications and found that chlamydia increased the risk of preterm birth about 1.7-fold. And this was true if you partition the results by case control studies or cohort studies. It also, when you subset for just high quality studies, there's still an increased association. And 4 additional meta-analyses also showed that chlamydia increased the risk of preterm birth. But even looking at the forest plot here, you can see that there's a lot of heterogeneity and variability in these studies. So some show a significant increase, others don't really show any association. And so digging down into the literature, we see that the primary literature really has kind of a mixed bag of results. So about 11 out of 23 studies show a significant association between chlamydia infection and preterm birth, while all 5 of the meta-analyses show there's a significant association. But one of the challenges is there's significant heterogeneity in these studies. So 4 out of 5 of the meta-analyses did show that chlamydia infection was linked to preterm birth regardless of diagnostic method, study type, or geographical location. But one meta-analysis found that this association was lost when they limited to high-quality studies using more stringent scale, when they limited to prospective studies, when they looked at specifically NAT detection of chlamydia, or adjusted for known confounders of preterm birth. So what are we seeing in this data that can tell us about whether this association is real or not? So this is a sampling of different studies where chlamydia has not been found to be associated with preterm birth. And so it's a busy table, but the first column shows the association with preterm birth, the timing of chlamydia infection, what subtypes were looked at, the timing of preterm birth, whether there was any adjustment for confounders. And really, I want the takeaway to be here that regardless of whether the authors looked at different subtypes, different preterm birth timings, or adjusted for demographic, medical, or preterm birth history, in these studies, they found no significant association. These are studies that did find a significant association either with preterm birth or with premature rupture of the membranes. And again, here you see studies defining preterm birth outcomes by different clinical subtypes, different preterm birth timing, and adjusting for different confounders. So looking at all this different data, something that I did notice was that not many studies are reporting the timing of infection. So which trimester chlamydia is diagnosed in. So this is one case control that did actually report that information. So they looked at chlamydia infection in 24 and 28 weeks, and this infection was diagnosed after the fact. So no information on whether the patients received antibiotic treatment before or after enrollment in the study, but they did not receive treatment as a part of this study. So what the authors found was that when chlamydia infection was detected at 24 weeks gestation, this significantly increased the risk of spontaneous preterm birth, though this association didn't hold when chlamydia was detected at 28 weeks gestation, and the authors proposed that this may be due to a lack of power. But here they did find that at chlamydia infection at 24 weeks gestation, there was an increased risk for spontaneous preterm birth, both prior to 35 weeks gestation as well as prior to 37 weeks gestation. So unlike with syphilis and gonorrhea, where there's real consistency in most of the data showing this association, we're seeing this mishmash of results with chlamydia infection. And I think there are a number of different complicating factors here. So it seems that with chlamydia, with gonorrhea and syphilis infection, that association with preterm birth stands regardless of the timing of infection and whether treatment has occurred. But this might be a complicating factor in looking at the association between chlamydia and preterm birth. So a few studies here are really investigating the specific timing of infection and diagnosis and preterm birth outcomes. And because these are population-based studies, we assume that chlamydia treatment is being conducted following a positive test, but very few studies report any information about a test of cure to really establish CT infection status throughout pregnancy. And we also know that chlamydia spontaneously clears in about 44% of pregnant individuals. So we could have the case here where some individuals are potentially getting reinfected with chlamydia at some point during pregnancy or spontaneously clearing their infection during pregnancy. And this is really muddying the waters on the association with preterm birth. Now, in terms of intervention studies, meta-analysis has shown there's no significant difference when we treat with antibiotics. So successful chlamydia clearance versus persistent infection or reinfection, no significant difference from 4 different studies. And when we look at treated versus untreated from 3 different studies, there's again, no significant difference. So summarizing this data on chlamydia infections, we really do see this contradictory evidence in the primary data. And so I think ultimately more data is needed with studies that specifically look at the timing of chlamydial infection and perform test of cure to understand rates of spontaneous clearance and possibility of reinfection. I think it's also important here to look at clinical subtypes of preterm birth, because there is new data emerging indicating that chlamydia infection could be a risk factor for hypertensive disorders in pregnancy, which is a risk factor for medically indicated preterm birth, which could lead to spontaneous preterm birth. So to finish off, I want to talk a little bit about the vaginal microbiome. So we know that when our optimal vaginal microbiome is depleted and we transition to this dysbiotic or imbalanced state, this is clinically referred to as bacterial vaginosis. And here we have overgrowth of diverse anaerobic bacteria. Symptoms of BV include abnormal discharge, odor, vaginal irritation, but can be asymptomatic in about 30% of patients. And up to 70% of patients experience recurrent BV after antibiotic treatment. But what's really important in the context of this work is that having BV significantly increases your risk for sexually transmitted infections, as well as pregnancy complications like preterm birth. So a meta-analysis of 18 studies assessing the relationship between BV and preterm birth showed that BV increased the risk by about 2-fold. There's also been data to show that when BV is diagnosed during the 2nd trimester, this increases the risk for both preterm birth and a low birth weight. Several BV-associated bacteria have been shown to cause ascending infection, so to vertically migrate from the vagina into the uterus, where they can be isolated from pregnancy tissues like the chorioamniotic membranes. In terms of antibiotic treatment, there is no evidence that treatment of either symptomatic or asymptomatic BV during pregnancy reduces preterm birth rates. So in this randomized control trial I'm showing in the table, BV was screened for at 14 weeks gestation or earlier, and patients presenting with BV were treated with intravaginal clindamycin, and this was compared to a placebo, no antibiotic control. And the authors found no significant difference in spontaneous preterm birth with this antibiotic treatment. And a meta-analysis further supports this, so 13 randomized control trials assessing treatment benefit for preterm birth. They found treating BV had no significant difference on the preterm birth outcome. So recent studies that have drilled down into the specific bacteria that are present in BV in pregnant individuals have really found that it's not necessarily the overall BV community that seems to drive risk for adverse pregnancy outcomes, but might be the presence of specific bacterial species that seem to drive the risk for preterm birth. So there's 2 recent studies published in 2019 that identified 11 bacterial species in the first study and 7 bacterial species in the second study that significantly increase the risk for preterm birth. And several of these bacteria, including Schnitzia sanguinogens, are known to cause ascending infection and have been isolated from pregnancy tissues. All right, so to summarize what I've gone through, we know that there's strong evidence to support that syphilis increases the risk for preterm birth and antibiotic treatment reduces that risk, as well as the risk for other adverse pregnancy outcomes. Gonorrhea is frequently, but not in all studies, linked to preterm birth risk, and meta-analysis supports this association with preterm birth risk, but we are lacking data on whether antibiotic therapies reduce preterm birth risk in the context of gonorrhea infection. There's major variability in the data on chlamydia and preterm birth risk. Antibiotic treatment does not seem to reduce the risk, and studies may be confounded by spontaneous clearance, reinfection, or the specific timing of infection during pregnancy. For bacterial vaginosis, similar to gonorrhea, we see that it's frequently but not always linked to preterm birth risk, and meta-analysis supports that association. But we don't see any effect with antibiotic therapies in reducing that preterm birth risk. But new data is emerging showing that specific BV-associated bacterial species seem to drive that risk. So perhaps targeted therapeutics addressing colonization of the genital tract with those bacteria could augment or affect the risk for preterm birth. So I hope one of the takeaways from today is the complexity of studying this. So because preterm birth can be caused by multiple different factors, this makes finding these associations really challenging, particularly when you have sexually transmitted infections that could increase the risk for other conditions that increase the risk for preterm birth. It makes finding that causality very challenging. Study design also represents a major challenge here. So large population-based cohorts have the benefit of providing a large amount of data, but we don't always have information on timing of diagnosis, treatment, and test of cure. And studies don't always separate out the different windows for preterm birth or clinical subtypes. So remaining questions that I didn't have time to touch on today: do co-infections with these different STIs increase the risk for preterm birth? The data is saying that in most cases, yes, but there may be different relationships with different co-infection of different STIs. What's the relationship to medically indicated preterm birth and gestational hypertension? As I've harped on about, the timing of infection and the timing of treatment. And ultimately, we want to be able to have a better idea of the causality and mechanisms of preterm labor induction. And so we know that several different independent events need to happen in order for preterm birth to occur. So you need to have contractions within the uterine smooth muscle cells. You need to have rupture of these chorioamniotic membranes, as well as remodeling of the cervix. And so some of the work we're doing in the Sycuro lab is investigating whether bacteria can trigger some of these preterm labor outcomes. So we're interested in characterizing BV bacteria that have been significantly linked to preterm labor. And we've been able to show that they produce these little enzymes called proteases that can break down structural components that are enriched in the chorioamniotic membrane, as well as the cervix, suggesting they may play a role in rupture or weakening of the chorioamniotic membrane and remodeling of the cervix. And the first data set from this work was published last year in MPJ Biofilms and Microbiome. So with that, I'd be happy to take any questions, and thank you so much for your attention today.
Thank you very much for your presentation. I'm going to the question place. So if you have questions or comments, you can put them in the Q&A box. There's a question about M. genitalium. Is there any role for Mycoplasma genitalium in preterm birth?
Yeah, so I didn't have time to talk about all of the different genital bugs, but there is some data to support that Mycoplasma genitalium is linked to preterm birth, as well as some ureaplasma species. So different bacteria colonizing the female genital tract do seem to increase this risk. but really understanding which ones specifically and the timing of that is still an open question.
Thank you. Is there any knowledge about the risk for viral STI? You presented with bacterial STI?
Yes, so there has been some work on that, particularly with HIV, and it's not as well studied for some of the other viral STIs.
Is there any evidence of a preconception STI bringing later in life problem with a pregnancy?
Yeah, so there has been select studies that have looked at this. A recent one was published with a cohort study in China, and they did find that preconception syphilis was linked to preterm birth risk, but they again did not perform a test of cure. So there's possible confounding variables with the potential for patients being reinfected and that being the true risk for preterm birth. So more work is definitely needed to design those studies in a way that we're repeat testing patients to really firm up that association between preconception STI and preterm birth.
And there was something you said about high blood pressure linked to STI in pregnancy?
Yeah, so I've got that slide here. So there are several studies coming out over the last couple of years that are showing an association with different bacterial STIs and hypertensive disorders in pregnancy. So one study has shown STIs increase the risk for preeclampsia. Both chlamydia and gonorrhea increase the risk for preeclampsia with severe features, and then chlamydia increases the risk for preeclampsia, severe preeclampsia, and preeclampsia resulting in preterm birth. So I think really studying these different subtypes of preterm birth is going to be important for dissecting those associations.
There's a comment, excellent presentation. I'm curious, why are you choosing the BV-specific bacterial route to study mechanism? Seeing that data on treatment effect is less promising with BV. Basically, will information you deduce be transferable to the STI mechanism for CT or NG, for instance, and ultimately inform treatment intervention?
Yeah, so some of the bacteria that are significantly associated with preterm birth, some of the BV bacteria, are also known to be associated with recurrent BV. So it's possible that in those treatment studies, patients are becoming recolonized with those same bugs or having persistent infections of those bugs in the case of antibiotic treatment failure. But I do think some of the mechanisms we're investigating could extend to STI pathogenesis. So we're definitely interested in exploring whether protease activity could be a trigger for preterm labor from these other bacterial STIs, and whether co-infection with BV bugs and STI pathogens further augments that risk by sort of synergistically remodeling the uterine environment.
Thank you. A comment, you've spoken about antibiotic treatment of BV. You didn't talk about probiotic. Would there be a place to prevent preterm birth with probiotics?
Yeah, I think it's early days to be able to answer that question. What we're seeing with vaginal probiotics is that they don't tend to long-term colonize the genital tract. And antibiotic treatment plus probiotic supplementation doesn't tend to be successful for reducing the risk of recurrent BV. But I think with designing better vaginal probiotics that have more potential for long-term colonization, there could be potential there for a supplemented therapeutic intervention.
Thank you. Are you going to planify a study, multi-center study, to see the effect of the treatment of CT-RNG on first trimester of pregnancy, on preterm birth, with treatment of test of cure tests and new screening before the end of pregnancy and status at delivery?
Yeah, I don't personally have a current plan to do that. But I would love to see that work done. I think to really nail this association, we do need a really well-controlled study like that.
A lot of work.
Yeah.
So I think that's all we have. No other question. Oh, we have another one, a late one. In the case of chlamydia, the risk-based screening guidelines in pregnancy are based on groups likely to have a higher prevalence of STI, but are there subgroups that are more likely to benefit from screening and treatment to reduce preterm birth? For example, the AutoTop trial found that BV treatment with azithromycin significantly reduced preterm birth among nulliparous participants.
Yeah, so there's, I mean, with these antibiotic intervention trials, there's definitely some mixed results, right? But the meta-analysis overall is showing that there's no significant benefit to treatment. But I think that's an excellent question. Are there certain groups that we should be screening and treating? I don't know the answer, but I think it's a great question.
I think that is all. So I would like to thank you very much for your great presentation on sexually transmitted infection and premature delivery. I would like also to thank Greg Penny, who's in charge of the logistic, and Brad for the posting on our website. And I look forward seeing you in November. The title and the exact date of the webinar is not finalized, but I promise you, you'll have an entertaining webinar in November. So I thank you all for your presence and hope to see you in November for our IUSTI Canada webinar. Thank you. Bye, everyone.